Thank you. Okay. Here we go. Hey, welcome everybody. Thanks for joining us today. This is Jen Kovich with eHealth Initiative. We've got lots and lots of people joining us for this session today to talk about telehealth and reimbursement. This is a really popular topic, surprise, right in the middle of the COVID-19 pandemic. Lots to get to today. We're just going to give folks a moment to log on. And appreciate everyone joining us. We know this is a really busy time right now, and there are a lot more pressing issues than coming to a eHI webinar. So we do appreciate everybody taking time out of their busy schedules today to join us. But this is a really important topic, and telehealth has been an incredible tool for people to use right now in the middle of this pandemic. So we've got great information for you today, a wonderful physician who's going to share what he's doing in his practice, and a wonderful resource from CMS who's going to tell us how to get paid for that. So a really great session today. While we're waiting for the rest of the folks to log on, if you want to share with us, let's see, what's a good thing to chat about? So when you get out of your quarantine, what is going to be the first thing that you guys do? Anyone want to share? I'm going to go to the hairdresser and get my roots done. Haircut, play golf. All right, thank you. Get my nails done, go to TJ Maxx. Somebody said that the other day. What is it about TJ Maxx? Go to the beach, Disneyland, yoga in a hot studio. Wow. Get married. Congratulations, Ginny Whitman. That's exciting. Visit your grandbaby. Wonderful. Daisy Vasquez. Great. Go to Jamaica. Super. Kick your kids out of the house. I am with that one. That's 2 teenagers, so we are all learning to live together. Go to Hawaii. Wonderful. These are all great. All right. Well, while we're waiting for the rest of the folks to log on, I'm going to just run through a few housekeeping items, and then we're going to jump right into it. Again, this session today is all about telehealth and reimbursement considerations. And Claudia, if you want to skip to the next slide there. We've got an incredible group with us here today. Andy Gila, who's the Director of Strategy Consulting at UpDocs, Dr. Phil Boucher, who is the at Lincoln Pediatrics Group, Emily Yoder, who's analyst in the Division of Practitioner Services, DPS, always an acronym, with CMS Center for Medicare and Medicaid Services, in case anybody was wondering what that CMS stands for. And there they are, a great-looking group. But you can see them for yourselves right here on video in front of us. Thanks for joining us, guys. Give a little wave. Housekeeping items. So everybody's muted, but that doesn't mean we don't want to hear from you. We want you to ask a lot of questions. In fact, the majority of the session today is reserved for Q&A. So there's a Q&A box there in the bottom. The sooner you get your question in, the more likely it is we're going to be able to get to it. So go ahead and type in your questions in the Q&A box, not in the chat box there. The chat box is for links that Ali and Sarah from eHealth Initiative are going to be sending out to you today. We've got copies of the slides. We have other resources and links that we will send out today as they get referenced today throughout the program. And we've got a whole slew of materials at our website. Thank you, Sarah Bryan on staff. If you go to ehidc.org/resources, we have a whole COVID-19 page with links to previous webinars on COVID-19, lots of reports and resources. I encourage you to go visit that. Next slide. So our mission, eHealth Initiative Foundation, we have been around for 20 years, and we are a very small nonprofit that convenes executives from all the different stakeholder groups to really figure out what are best practices right now going on using tech and innovation. Next slide. And generally, we are focused on value-based care, interoperability, privacy and security, and analytics. We spend a lot of time on SDOH and FHIR, transparency, prior authorization. Next slide, Claudia. Next slide. But right now we have been spending really the last 6 weeks and probably the next 6 weeks focused on COVID-19, doing bi-weekly webinars around COVID-19, work groups around social disparities, health disparities, talking about different ways to use telehealth, talking about different analytics that can be used, sharing practices from all different sorts of medical practices across the country and hospitals and provider groups, hearing from vendors that are out there in the field right now using new tools and figuring out how to implement them. All of this really to help the industry right now talk about what's working and share with each other about what's working or not working. Coming up in the next couple of weeks, next week, April 28th, go back, Claudia, we're going to be talking about addressing capacity and cash flow with virtual care. We know that cash flow is a big issue right now. We're going to be talking about wearables and using them to detect infections. That'll be actually with Fitbit coming up, so that's going to be exciting. Telepsychiatry, another great one coming up on May 21st, and one that's not actually mentioned on here. We have a great conversation coming up with the American Cancer Society about dealing with cancer patients right now during the pandemic and talking with them a little bit. That's with their medical director, Dr. Len Lichtenfeld, who's going to be joining us next week. So more information about that, and check back on that COVID-19 page. All of these are free and available to the public, so feel free to share that information and those links. Next slide. And a big thank you to UpDocs. As I mentioned, eHealth Initiative, we are a very small foundation, nonprofit, and all of the programming that we are putting on is really due to the generosity of organizations like UpDocs, that are allowing us to share this information in such a broad manner. So great thanks to UpDocs, and who's doing some really exciting things around telehealth. So really, this is a great piece today, and I'm so glad that they're supporting us. I really want to thank Andy and UpDocs for doing that. Next slide. So I'm going to actually turn it over to Andy so he can talk a little bit about what they're seeing. They've got a number of clients working in telehealth right now, and then we're going to get right after that, we'll get to the doctor, and we'll get to CMS. So Andy, you want to kick us off?
Absolutely. And so I just want to say thank you to eHI for having us. Thank you to our awesome panelists, which you will get to meet here shortly. And thank you for everyone taking the time to listen to this discussion. We're very excited, and hopefully you'll find tons of benefit in it. So like, Jen mentioned, I'm Andy Gila. I lead up our strategy consulting group here at UpDocs. I've been at UpDocs for about 3 years and was early on helping build out our telehealth initiative. So just like many of you have questions, I know it's definitely been a journey, so we're excited to get into it. So if we go into the next slide, what we really want to kind of focus with you guys today is how to grow your practice through telehealth with reimbursement considerations. So many have considered telehealth for multiple years. We'll get into why some of the limits existed and kind of how this pandemic served as a catalyst for growth. But as we think through not only how to implement now, what are the reimbursement considerations going on right now with all the changes happening because of the pandemic, how to thoughtfully think through the future in kind of a post-COVID world with what might continue to change from both a policy and reimbursement perspective, but how can you best position your staff, your organization to best treat patients while also knowing the realities of, the cash flow and reimbursement requirements that are there. So Dr. Boucher will definitely help compare both what he was doing beforehand, what he's doing now and afterwards, and Emily will help provide some great insight into some of the things that CMS is considering and other helpful hints. So if we go to the next slide, again, we're really just focusing on leveraging telehealth specifically during the pandemic and how the needs were addressed. But what we really want to call out is it served as a catalyst to implement and grow telehealth in general, but the need has always been there. It helps kind of remove some of these barriers. But I think what's really important is to understand how can we enable, various organizations to kind of think through not only the change management that needs to be set up, but what kind of visits make sense to do in a telehealth setting. How can you get reimbursed for some? What are some of the visits that might make sense but might not be reimbursable? And what are those general considerations to think through as we kind of try to imagine what the world will look like on the other side of this? both for all of us in our day-to-day lives, for our patients, but also from a care setting perspective. So if we go on to the next slide, I just want to highlight some, we like to call these myths, but these were some of the often brought up challenges that we at UpDocs would hear from many of our customers. And what we hopefully will try to dispel both here today, but in general, is that these things are exactly that, myths. There's a lot out there about, needing to get new computers, cameras, or other expensive equipment, and why considering how to approach telehealth can really show that these can be minimal considerations rather than these large blocking considerations to get started with telehealth. It will take a long time to get staff running up and trained. So we've learned that that is just not the case, and we've actually seen many organizations over the past few weeks be able to get set up in as little as a day, and even large organizations in as little as a few days. And I'm sure Dr. Boucher has some great examples he can share there in terms of how he even got started with his practice. My patients, especially the older ones, aren't comfortable with the technology. I think what we've seen during the pandemic in general is just how many have embraced technology, not only for telehealth and medicine, but across the board, given social distancing and how we have to keep in touch with each other nowadays. But we've even seen at UpDocs just how many customers or others that we work with had concerns about their elderly population not having the ability to take advantage of this. And what we're seeing is actually quite the opposite. Many in that segment of the population tend to actually be even more engaged when these options are provided to them, because it helps remove some of those barriers to care that they have in a conventional setting. And again, the big one, I won't get reimbursed for telehealth services. That's just not the case. There are definitely some things that you will not get reimbursed for, but there are also many things that you can get reimbursed for, and that will continue to kind of change and evolve, and we're excited to dive into that today. So if we go ahead to the next slide. Again, we just want to call out some of the things that are going on, specifically regarding reimbursement and just coverage in general. So there's a lot of regulatory changes, legislative changes, and even changes at CMS that are helping shift not only how patients can be treated and how reimbursement will affect, but even how state licensure might affect the ability to care across state lines, how the federal government and state governments are making previous types of visits or restrictions in terms of where someone had to be to have it be a considerable reimbursable visit, how that's changing, and also what some of the fee rates might look like. So we're really excited to dive in a little bit deeper into some of that to compare not only what life was like before this pandemic kind of served as a catalyst to make these changes, but what life is like today with some of these changes and what are still some of the pain points that many of you are experiencing, but what are some of the benefits that are being reaped. And as we think to the future in terms of now that, we think telehealth is here to stay in some capacity, what are some of those considerations that many are raising up to CMS? What are some that, as a practitioner, Dr. Boucher can share that he's experiencing, and also that patients are raising as well. So just to kind of give you an idea of the various lenses we'll try to bring to this conversation. So as we go to the next slide, I would be, really excited now and honored to introduce our two panelists. So I'll let Dr. Boucher start off and introduce himself.
Hi, I'm Phil Boucher. As Andy and Jennifer said, I'm a pediatrician in Lincoln, Nebraska in private practice. And we are a small practice of 10 pediatricians and I think we're going to talk about it more, just our experience with telehealth, but it's been something that's come to the forefront with a lot of my physician friends and colleagues, and everybody's been asking, how to get started in telehealth because it's so important, and we had such a little ramp up to doing it at full capacity that everybody's kind of scrambling to figure it out.
Awesome. Thank you, Dr. Boucher. And then I'll also pass it over to Emily to introduce herself.
Yeah, hi, I'm Emily Yoder. I am an analyst in the Division of Practitioner Services, which is in the Hospital and Ambulatory Policy Group in the Centers for Medicare. I have been with the agency for a little over 5 years, and for about 4 of those years, I've been working on telehealth, and I've been, I'm on the team of people here at CMS who's been working to implement the various sort of regulatory and waiver type changes that CMS has been doing in response to the COVID-19 pandemic.
Awesome. Thank you, Emily. So again, we're really excited to have these panelists with us here today. So let's go ahead and get started and dive right into the first question. So this one will be for you, Dr. Boucher. Can you share a little bit about what you were doing before the pandemic, a little insight into maybe how your practice got started with telehealth and what that on-ramp looked like, and then what types of visits you would use for it, talk a little bit about reimbursement, and also other types of visits that maybe you didn't receive reimbursement for, but you also found value in.
Yeah, so we are a practice that's embraced technology, and to be honest with you, everything that you said on that slide with the handsome guy and doctor guy in the white coat, those were all the true things that we were experiencing in our office with the idea of doing telemedicine. And luckily, I kind of knew you, Andy, from our my work on my podcast with UpDocs, that we had the idea of, okay, this is what telemedicine would look like, but we weren't doing it on a regular basis. One, because our patients were not savvy to it and they had no idea that it was an option. And two, because we just felt like the overall hurdle of getting started was high for all of the reasons that you mentioned. And then all of a sudden it was, patients don't want to come into the office anymore. And we don't really want patients to come into the office anymore, but we have to keep the lights on and our employees employed. And CMS and everyone else is responding by allowing for telemedicine visits, and commercial payers are responding with wanting to keep their patients out of the offices as much as they can. And it was like, okay, we got to get this figured out because we can do this, and our patients will probably appreciate if they can connect with us, even during this time where social distancing and quarantining and all of those things is going on. And so it quickly came to the forefront of, okay, do we have the technology and platform in place to do this? And then how do we structure a visit? What does that look like? How do we get the patient from calling in and asking for a telemedicine visit to actually being in the room? What kind of technology do we need? Well, we quickly figured out that what you have on your phone is all you need on both ends to do a telemedicine visit. But that was one of the big hurdles, is, well, we don't have the technology to do it. And in the past, you had to have patients at a specific site for them to do a telemedicine visit. And all of those rules have fortunately kind of been relaxed so that people can get those necessary appointments without the technology restrictions. And just, what's the workflow going to look like for our staff? How do they actually get a patient in a telemedicine room and collect a history and do the note and do the charges and everything like that? So those were all things that we had to quickly figure out in order to jump on to doing telemedicine on a regular basis. And to jump ahead a little, it's been so well received by both our staff, our physicians, and the patients. The patients love being able to connect and get their questions answered and talk through their issues without having to come into the office. Patients do not want to come to the office. And if we weren't seeing them by telemedicine, we would just be, watching Netflix all afternoon around here, because there wouldn't be any patients coming in to talk with and help, and they would just be sitting at home wishing they could talk with somebody. So it's allowed us to keep our patients in the loop and stay connected with them and deal with their issues during this difficult time. So it's been a huge win for us, and it was something that, like, I feel really proud to be a part of it and be a part of this webinar, because it didn't exist a month and a half ago, and we didn't ever do telemedicine visits. We had the idea that we wanted to do them, and maybe there'd be some way to do them in the future, but there was never any push to actually get it started until this all started.
No, that's fantastic. And I just want to follow up to one point you said on there, because, just being able to get it up and running, like you said, just a few weeks ago, to, react to this and help, serve your patients. Can you talk a little bit about, how you guys have been able to set expectations for the patients, and their parents in this case, in terms of what to expect? And also maybe, because I can even see some of these questions coming in terms of, like, how are you capturing things like consent? Are you documenting and scheduling the same way? I know we've talked a little bit about this in the past, but, I'll let you as the expert chime in on that.
Yeah, so a few of the different things that we've done in terms of the patient expectations is, fortunately, we have text messaging capabilities with our patients. And so through UpDocs and our EMR and everything like that, we're able to text patients and say, hey, would you like to do this as a telemedicine visit instead of coming to the office? And most of them, yes, I would really much rather do that. Some of them, it's like, well, how are you going to look in my ear? Well, you probably do need to come to the office so we can look in your ear, or do some of the things that we really can't do over telemedicine. But a vast majority, and a lot more than we expected, we're able to handle or get by over telemedicine, understanding that we're in the midst of a pandemic and we have to kind of make do with what we're able to do while keeping patients safe, keeping our staff safe, and everything along those lines. We're able to text them consent form, like PDF, that they're able to just send back to us securely over text message. They fill it out on their phone. So basically anybody that has a phone can do the consent, and then they get the text message that gives them the little link to click to join the chat. I haven't had any patients that have not been able to figure it out, which is saying a lot, because a lot of times it's the parents or grandparents that are with the child, and they often struggle to get the platform up and running, typically, I would think, but everyone's been able to just like click straight through, join the call. You know, the nice thing about the phone is you can just kind of like hold it right up to the child and easily, you know, capture the rash or whatever it is, so that I can see on their end what they're seeing, and then step back and say, okay, this is a child that's not breathing difficulty. They look well hydrated. I can't look in their ears right now. I can't swab them for strep, but I think we're safe watching them right now. And we can see how things go over the next 24 hours, rather than bringing you into the office, potentially exposing you unnecessarily, potentially exposing our staff or our providers unnecessarily. Let's just check in again tomorrow over telemedicine and make sure things are going okay. And then we do the same, you know, here's the things to make sure that if something changes, to let us know and we can make a new plan. So patients' expectation is met because they're still getting to see us. They're still getting to talk through their problems. And we're adjusting the expectations of, like, we can't necessarily solve all the problems right now over telemedicine, but we can get by with what we need to make sure that everybody is as safe as possible. And patients have been so happy to do that, and just grateful that we're able to be with them in their home, looking at their rash, talking about a behavioral concern or something along those lines, in the midst of all of this uncertainty and pandemic. And I will say that my patients, like the kids, love it too, because I get to see their dog and their pictures that they want to show me and all those sorts of things. And they get to see me on their phone, which what kid doesn't love, like playing with their parents' phone. So it's like the opportunity to play with the phone. And I always make the joke that most of the kids laugh at is like, okay, now, you know, we have to wear our masks and everything like that. So I have to show you my mask. And then I do one of these. And the kids love it. So, I mean, like little things like that you can do that really just make the experience just as good as being in office. I mean, you don't get stickers at the end, but you don't get shots either. So it's a win-win for the kids.
That's awesome. And I appreciate that insight on your part. I mean, it definitely sounds like you all have been able to, really adapt to this while still preserving that experience, kind of like you showed there, which I love, by the way. And it almost feels like you're starting to even enable that transition to not only telehealth, but would some would even consider virtual care. So definitely hold that thought. I'll be back asking some more follow-up questions on that. That's for sure. So if we go to the next slide real quick, I mean, I just want to kind of summarize some of the things that Dr. Boucher mentioned, because really some of these key drivers that are very consistent with what even a recent AMA survey found too. It's, that increase for convenience. So you heard about how many patients would much rather have this option for telehealth rather than, get ready to make the drive all the way over there. I know right now schools, most of them are closed, but even beforehand, I know Dr. Boucher had mentioned how many parents like the minimal impact you would even have on taking their child out of school, because you can do the appointment kind of in the parking lot as well. So there's all those things to consider with patient, convenience, the work efficiency as well. So it's better for both sides. I think it provides some more streamlined ways to access that care. And even in some aspects, we hear many people even providing after-hours care because it's more convenient, because many clinicians can even provide it from the comfort of their home rather than having to be physically in the office to even provide that care remotely. And again, I think Dr. Boucher, you showed a great way how you can continue to improve that patient-doctor relationship even while you might not be actually there physically in the office. And so being able to have access to this care, continues to increase that patient safety, because rather than, you guys watching Netflix and the patient sitting at home not really knowing what to do or what to ask about their care, you're still finding ways to do it. And another point we'll touch on later is many of these visits are reimbursable, and it still provides a way to, find that new stream of revenue. So I definitely thank you for that. So then if we kind of go to the next slide, I want to shift gears a little bit. And, Emily, I want to ask you, I'm sure it's been a crazy time over there at CMS with everything going on. And, we appreciate just the swift actions of the agency. But can you share a little bit about, some of the key actions that CMS has taken in response, and kind of going a little deeper in terms of what caused those and what you're seeing pay off?
Yeah, absolutely. I'm happy to walk through those. So just a quick bit of background. I'm sure you're all very, very familiar with all of the restrictions surrounding Medicare telehealth. The current law that is still in place, it is still in the statute, only allows Medicare to pay for telehealth services in certain circumstances. Most significantly, only beneficiaries in rural areas are eligible for telehealth services, and the beneficiary must be in a medical facility, so not in their home. So in response to the COVID-19 pandemic, Congress gave the Secretary the authority to waive certain restrictions. So the first set of waivers was for the geographic and site of service restrictions. So under these waivers, we were able to say beneficiaries who are in urban areas, and most crucially beneficiaries who are in their homes, can now receive telehealth services, and the practitioner furnishing those services can be paid. I would note that there is actually additional waiver authority that we've been given through the CARES Act that would allow us to waive up to all of, but certainly many parts of the existing restrictions for Medicare telehealth that are in the statute, and we are currently considering how best to deploy that additional authority. So subsequent to the waivers, we also undertook emergency rulemaking to address any sort of remaining regulatory hurdles that we were able to identify at that time. And I'm going to summarize sort of some of the key provisions in that rule right now. So we added over 80 services to the Medicare telehealth list. These include initial inpatient, initial nursing facility visits, emergency department visits, initial and subsequent observation services, inpatient nursing facility and discharge day management, home visits, and a number of physical therapy, occupational therapy, and speech language pathology services. We also actually modified the billing requirements for Medicare telehealth services. So rather than putting place of service 2 on a claim to identify it as Medicare telehealth, we have instructed practitioners to put whatever the place of service they would have used had the service occurred in person, and append the 95 modifier to the claim to identify it as Medicare telehealth. So, for example, if a physician would normally furnish a visit in their office outside of the PHE, if they perform that visit via telehealth, then they would put place of service code 11 and then the 95 modifier on the claim. We also eliminated a number of frequency limitations for subsequent inpatient and nursing facility visits and critical care consults. We also elected to exercise enforcement discretion regarding there's certain statutory requirements for patients who are receiving ESRD services via telehealth, and we were able to waive those as well, or rather exercise enforcement discretion for those as well. We amended our regulations text to clarify that the definition of interactive communications technology could include a smartphone. We had heard from the community that certain of our MACs had been interpreting that language to mean that smartphones, because they are phones, were not permissible under the statute. So for our communication technology-based services, and these are services that are not that are virtual and that utilize telecommunications technology, but they are not actually considered to be telehealth. We removed the requirement that these be furnished to established patients, and we expanded the practitioners who are eligible to bill for these services. Previously, this was practitioners who could independently bill for E&Ms, and now we changed that so that it is practitioners who cannot independently bill for E&Ms can also bill for these services. So that would be, for example, like licensed clinical social workers, clinical psychologists, and the various therapists. We also decided to cover and make payment for telephone evaluation or assessment and management codes. We had long considered these non-covered under the physician fee schedule, but in light of the pandemic, in particular, that we've heard that for certain beneficiaries, they really prefer to use audio-only telecommunications technology. We decided that we would activate and start making separate payment for these codes. We also are electing not to enforce the requirement that's in the CPT code descriptor that they be furnished to established patients. We also revised some of our supervision requirements to allow that for the duration of the PHE, direct supervision can be provided using real-time interactive audio and video technology based on the clinical judgment of the practitioner. For remote monitoring, we removed the requirement that there be an established patient-practitioner relationship modified requirements around consent so that they can be obtained subsequent to furnishing the service. We also clarified that RPM services can be furnished to patients with chronic and or acute illnesses, and confirmed that RPM treatment and management services can be furnished under general supervision. For teaching hospitals, we changed some of our requirements there around supervision. So medical residents can provide services under the direction of a teaching physician. So in addition to being able to directly supervise a resident with their physical presence during key portions of the procedure, teaching physicians can now also provide supervision virtually using audio-video communication technology. And finally, for the office outpatient evaluation and management visits, when these are furnished via Medicare Telehealth, we are actually adopting the framework that we finalized in the 2020 rule for CY 2021. We finalized in that rule that medical decision-making or time could be used for purposes of level selection, and that history and exam only need to be conducted as clinically necessary. So we are, on an interim final basis, also implementing that change for purposes of the COVID-19 pandemic. And I really want to highlight this because in the context of Medicare telehealth, and as practitioners are moving more and more of their practice to a virtual practice, this is it's important for practitioners to be able to bill and be paid for the services they're performing and not be hampered from, for example, selecting a higher level evaluation and management visit by the fact that they are not able to obtain sort of a detailed physical exam from the patient. So we really wanted to preserve access to billing for these higher level codes. And so that is a lot of information, and so I will pass it back to you, Andy.
Awesome, thank you. And that was definitely helpful, and I think it's generated a lot of discussion in the Q&A. The one immediate question I have is, would there be a good link to direct the folks to for many of these things? Or I'm sure we could probably perhaps something afterwards, because I know that's a lot of content, but it's very helpful and by what it's done. And we'll definitely dive in a little bit deeper into some aspects here as the conversation goes. But thank you. I mean, thank you both for providing that. And I think thank you to CMS for, I think, taking a lot of much needed action very quickly during this time to help everyone. So that's really exciting to see. So if we kind of then go to the next question, I think just to shift gears. So Dr. Boucher, I know.
Before we move on, just answer the one, we've just gotten like 20 questions in for Emily just about, are these going to be extended at, when do these extensions end? Are they going to end after the pandemic? If you could just answer that question, because we will get it another 20 times.
Yes, absolutely. So right now, all of the waivers and the regulatory changes are tied to the COVID-19 pandemic. So once that public health emergency is declared over, then basically all of the stuff that I've just discussed will go away. That being said, we do have sort of a normal rulemaking process. The physician fee schedule is used to sort of, under normal circumstances, make changes to sort of physician reimbursement for virtual services, and we are also working on developing that rule. And we're certainly taking into consideration what we've heard from the physician community, that many of these changes that we've been able to do through all of these incredible legislative and regulatory flexibilities would be helpful to keep long term.
Thanks. Sorry, Andy, back to you.
No, that's a great question. I mean, definitely no shortage of things going on when it comes to the ever-shifting world of reimbursement. So that's helpful there. And then I think Dr. Boucher, kind of, like you mentioned, getting started with, during this time. Can you talk a little bit about what you noticed in telehealth usage prior, to the pandemic kicking off? I know you guys were early on in discovering that, and kind of what you've noticed now, and kind of following up then based off a lot of the information that Emily shared, what you're seeing in terms of reimbursement, not only from, I'm not sure how much is applicable for the type of practice you do for CMS, but in terms of commercial payers, any behaviors or patterns you notice in terms of well visits, medication checks, what's being reimbursed, what isn't, and is there any consistency out there when it comes to the commercial side? So I'll pass that on over to you.
Right. So, I mean, in terms of usage prior to usage now, it's just like almost a straight line upwards, because everyone is realizing that it's important, it's useful, and if we don't do it, then we're just going to be not serving our patients or getting reimbursement for what we're doing and paid for the work that we're doing. So it's been huge, and we've seen just massive growth in that, not just in our practice, but in our community and around the country, speaking with many other physicians, that telemedicine has become a big part of their practice almost overnight, going from 0% to 30, 50, 70% of their visits as telemedicine visits. So it's been very quick. And I appreciate, not just the private insurance or commercial insurance, but CMS and everyone being so quick to jump on the gun and make it so easy for physicians to keep seeing patients by doing all of those measures to relax everything. In terms of reimbursement, you're right. We don't have any Medicare patients, but what we have seen is insurance companies have come on board with telemedicine and with the importance of providing for parity with those office visits. So what we've seen is that we've started to get some, we've just been doing it for enough weeks now where we've started to get payments back for the visits and have seen really good consistency across payer or between an in-office visit and a telemedicine visit. So that's been really reassuring to us. We're still getting a lot of data in, and we'll have more data in the next 2 weeks, and I can talk about it in a future time. But we have so far been very pleased with the reimbursement that we've been getting from the private payers across the board for telemedicine visits, doing behavioral visits, seeing patients for sick visits. We have not done well visits yet. I know that was asked on the questions, and I don't know what Emily would have to say about like annual visits and those sorts of things, because we haven't had luck yet getting guidance on how to do a well visit, because of the need for immunizations and things along those lines and the screening that you kind of have to do in the office. We haven't jumped into that yet, but I think that is something that would be very valuable if that became available.
Absolutely. And actually, Emily, is there anything you'd like to add to that in terms of any guidance on well visits or if any considerations ongoing?
Yeah, so I can't speak to well visits for the pediatric population, obviously, but the annual wellness visit for Medicare beneficiaries it already was a service prior to the pandemic that you could furnish via Medicare Telehealth. The problem that we're having now and what we've been hearing is that because patients no longer have to come into a medical setting in order to have the annual wellness visit, a lot of the things like vital signs that could previously have been obtained in the medical facility where the beneficiary was, the beneficiary may not have access to similar equipment at home in order to sort of self-report those vital signs and things like that. So we're definitely considering how best to address that particular issue so that Medicare beneficiaries can continue to receive these annual wellness visits.
Awesome. Thank you, Emily. And then Dr. Boucher, I know some questions we're seeing here as well in terms of, how you guys are performing eligibility checks. Is that something that's kind of been going through the typical process even for these telehealth visits? And have you encountered or kind of are there any plans in terms of dealing with any issues where if insurance does not seem like it will be covering how to proceed or any guidance there you can offer?
So eligibility checks just the same as we usually do. So really no difference there in terms of our normal workflow. I think everyone is just crossing their fingers for the most part and hoping that these visits get covered, knowing that we're providing a service to our patients and our patients will in turn appreciate that and understand that, okay, things didn't go exactly as smoothly on the visit. Like there was the bandwidth issues and, the audio cut out maybe or something like that, or a cat jumped in the way of the video or something. But just understanding that our patients want to be in their medical home. They want to get that care from their physician. And so everybody's going to realize, okay, they were there for me during the pandemic. I'm going to go back in for that visit that we're making up for now. And so some of it will probably be essentially charity care that we're doing where it's just keeping us moving with patient care and knowing that it's building that customer, that patient experience and patient loyalty to us as well. So, it's difficult to break that down numerically or financially,
Absolutely.
but we just know that karma will pay us back in the end.
Absolutely. That's a great point. And actually, that's a good transition for the next slide if we go towards it, because I know you shared a little bit of some of the the lessons learned and kind of what you guys are seeing and reacting to it. So this question will be a little bit for both of you. I'll start with you, Emily, in terms of if you could share what are some of the things, you guys are seeing just based off reactions or based on some of these questions. So any common themes you can share there, and I guess what has been a surprise, if anything.
Yeah, so it's a little bit difficult to speak from the agency's perspective about sort of what the lessons we've learned are. It's incredible because it's basically been 2 months since we started rolling out these additional flexibilities, and it feels like so much longer. But just speaking for myself only, I've actually been amazed at how quickly we've been able to modernize our approach to pay for virtual care or care that utilizes telecommunications technology. So those statutory provisions for Medicare telehealth are around 20 years old. And while we've always paid for things like remote interpretation of diagnostic tests, which can have a sort of virtual component, or things like care management that also can utilize some form of telecommunications technology, it's really been in the past couple of years that CMS has made steps to pay for things like the virtual check-in or remote patient monitoring that more fully utilizes communications technology. And so given this kind of relatively measured evolution, it's been really, really remarkable to watch how through the combination of these waivers and regulatory flexibilities, we've been able to go from paying for just basically a handful of virtual services to paying for as much virtual care as possible in just a few months. So that's, I guess, what I would share from my own perspective.
Absolutely. No, it's very insightful. Thank you for that. And I would agree there too. I mean, I think just from at least on the upback side as well, we've seen an unbelievable amount of organizations get it set up and running and just kind of adapt to it. So I think it's just really impressive to all the clinicians and their teams out there in terms of, what they've been able to do. And on that note, kind of same to you, Dr. Boucher, I know it's been a crazy couple of weeks, but in terms of any prominent lessons learned or any patterns you're seeing or any surprises, either good or bad, you'd like to share?
I think just making sure that you're really talking with the payers on a regular basis to know what they're wanting, because like Emily had said earlier, going from the place of service code to the in-office to teleservices and changing that back and forth, like we've had to adapt and the 95 modifier and everything like that. But if you just talk with the insurance company as much as you can to make sure everybody's on the same page and knows what's going on, then it's much smoother. And knowing that to some degree, we're going to have to probably do lots of revisiting claims to make sure that we're getting appropriately paid for them. But I have been surprised at how quickly things have turned on and how quickly the payers have responded. So that is the surprise, is how quickly things were able to change.
Yeah, that's great to hear. And so I'll have one more question for you guys here on the next slide. And then because we want to make sure we save some time too for all the other Q&As we're getting in from the audience. And as we kind of think of it going forward, because I know when we started this, there was a lot of considerations that we've heard, not only from you, Dr. Boucher, but from many other organizations we work with about like how telehealth could be used to grow the practice, not only from the reimbursement standpoint and understanding what kind of visits can be moved over so you can do more of them or do them more effectively. But also it's very important when you factor in things like, acquiring new patients or retaining existing patients, because so much now out there is changing to provide these types of services. And not only for telehealth, but also for texting and other things of that nature, because I think this is highlighting both the demand that was there on both sides, both in the patients and in the clinicians world. And thanks to, the quick action of both CMS and other commercial payers, I think it's showing that this is kind of going to be the new normal. So in that lens, can you guys both share about what are some of the common questions people are asking in telehealth about a post-pandemic world? And maybe, I know you can't speak for the agency, Emily, but in terms of your own thoughts, like what do you think we should expect or might be some patterns we see? And then same with you afterwards, Dr. Boucher.
Yeah, absolutely. I'm happy to speak to that. So obviously the main question that we've been getting and that I just actually answered here is how many of these flexibilities can we really expect to sort of stay in place in the post-pandemic world? And as I said, right now, everything is tied to the PHE. And so when that ends, the flexibilities would theoretically expire. However, we are also considering sort of through our regular rulemaking process what sort of flexibilities we might want to adopt on a more permanent basis for the things that we have the authority to do. Obviously, pointing to that a lot of the restrictions on where the patient has to be and, you know, the technology, those are actually in the statute, and so that would be to Congress to sort of make that decision and implement any sort of flexibilities through legislation. I will say that being said, like the world is changing obviously in many ways. I mean, just on a personal note, like my father, who lives in Oregon, I live in Maryland, I could not get him to Skype me, but he was able to have like a Skype check-in with his doctor and have Medicare pay for it. And so just like in that one small way, I think it points to sort of a larger sort of shift, both in terms of the ways in which we think about paying for care, but also I think the experiences of patients, especially like, you know, patients like my dad who are maybe not the most sort of tech amenable prior to this, but it's just sort of changing the medical landscape in a way that I think is going to be really meaningful in the future.
Awesome. That's exciting too. I mean, we keep hearing a lot of that as well. We even had an employee here whose 93-year-old blind grandmother was able to navigate and get care through a telehealth visit and while she was remote in Arizona. So it's truly incredible. How about you, Dr. Boucher?
Yeah, I mean, patients and families are all on their phones. Like this has just allowed us to catch up to where patients have been for the past decade. And so, you know, for example, we're doing all of our ADHD, anxiety, depression visits over telemedicine, and it saves the patient so much time driving across town, sitting in our waiting room, sitting in our exam room, chat, and then back to school. But wait, it's almost lunchtime, so we got to stop and we got to get lunch too. That's like 3 hours out of a family's day for a 15, 20-minute visit. Whereas if they can go to the school, get the child, get them sit in the car, do the telemedicine visit, back to class, enjoy your lunch, and get back to work. Like patients are going to want that, and we're hopeful that that will allow us to offer that service, you know, in September or December or next, you know, in a year from now. And so my hope is that everyone embraces this and realizes, okay, this is just required us to catch up to the future, which is now, and to cover those services on a continuing basis because it keeps patients where they want to be. And like you were alluding to earlier, Andy, it is a way for us to be with our patients where they need, which helps us to acquire more patients and build customer patient loyalty because we are going the extra mile to make it convenient for them. We're not saying, okay, you have to come into the office because I have to look at you in the face when we talk about ADHD and depression. I'm not even going to do a physical exam, but you have to literally come sit in front of me. Patients don't want to do that. Patients don't want to call our office to make an appointment. They want to do it on their phone. They want to text us, and they want to get a text when their room is ready so that, you know, they can sit in their car and not sit in our waiting room. And then they can get a text that says, come back to room 29. And then they just scurry down the hallway to their room. This has just required us to really take the next leap with our patients technology-wise, where everybody has just been waiting for a reason to do this. So I think that, and my hope is that as we move out of the pandemic into the post-pandemic world, that a lot of these changes stick around and improve patient care and the patient experience.
Absolutely. I mean, I want to say thank you to both for that because I think it's highlighted, you know, and it refers back to some of those myths we talked about earlier. I think you both shared examples and stories of, you know, how at least starting to put the infrastructure in place and getting staff to think about a way of, you know, augmenting those in-person visits with virtual care and knowing that those patient expectations, they're already there, they're already savvy, they're kind of demanding this, and it actually might be more risk if, you know, an organization doesn't shift this way because they might be at risk to lose patients. So while there are still some very real reimbursement questions out there, you know, not only on the CMS side, but on the commercial payer side, I think we've seen progress on that front that shows virtual care, not just telehealth, will be here to stay. And I mean, just to share with you guys, we've seen over 15,000 providers get started over the last 3 weeks at UpDoc and impact a wide variety of patients. And the feedback has been exactly what you guys are sharing. Everyone's there for it. We're ready for it here. So I think it's continuing to push forward on the reimbursement. So again, I just want to thank eHI, our panelists, and the audience. I'll pass it back over to you, Jen. I know we have a lot of great questions to get through. So I will go ahead and let's not waste any time from me. So I'll pass it over.
No. This is great. Okay, one question we've been getting a few times here, Emily, for you is about under the COVID-19 telehealth waiver that providers and patients have to use devices with audio and visual capabilities. So in a lot of situations, you have a provider or a patient with a smartphone, but the video doesn't connect and audio is the only option. So can the provider still get reimbursed for that visit if they're not able to use video?
Yes, so that's one of the reasons why we activated and began making payment for the audio-only, like telephone evaluation and management or assessment and management codes, because they do provide some reimbursement, granted not the same as an office visit, and we've definitely heard that from the community, but they do provide some reimbursement for audio-only services. I would also point out that through that CARES Act authority, we do have the ability to waive the audio requirements, and we're very sort of seriously considering whether we want to pursue that and for which services. So hopefully there'll be some good news there very soon.
You mean waive the video requirements?
Mm-hmm. The interactive audio video requirement, that's correct.
Okay, great. So I think that's helpful. Dr. Boucher, one of the questions that we get quite often is how are you integrating this information into the EHR, or do you just type it in afterwards, or how does that work?
So we have different workflows that different physicians in our office are using. Some, have half the screen with the telemedicine platform video, and then half the screen with their EHR, and are kind of just typing as they go or doing their notes after the fact. I fortunately have a scribe who sits right off camera, and the kids all want to know what he's up to because they see him in the office when they come in, and they want to know where Grant is. But that has really helped us, is to be able to do them at the same time. What we can do too is have my nurse get on the computer first with them, get the history, make sure that all that information is correct, and then literally hand me the computer and I can go and do the visit over telemedicine. So it allows me to keep going with my patients and get the important things that I need to done without sitting and waiting and watching them try and load and having those things fail and then hopping on. So that has helped with the workflow, but that's something that we've kind of had to figure out for our office and what works best. Some of our physicians just have two computers, one that's doing the telemedicine audio video component of it, and then the other where they're charting and accessing the chart. So in the nice thing, I think it's nice in one way, is that really you can have the telemedicine platform divorced from your EHR so that you don't have to wait to have them integrated in order to get started, which just allows you to sign up with the telemedicine platform and get started on doing visits rather than waiting for, all the back end tech stuff to be worked out, so that you can start doing telemedicine visits today if you wanted, without having to worry that how long am I gonna have to wait in the queue and what are all the tech hassles that are gonna come up. Then once you get it integrated, then you can just type the patient's name, Jane Smith, and it will pull up their cell phone number and can text them the link so that they can log in and enjoy the visit in a much more quick fashion. But having that flexibility of systems allows for you to get started much faster. So that's really helped us as we figured it out to just revert back to, okay, we can still chart no matter what. Even if we have to do FaceTime or Skype or those sorts of things, or Zoom or whatever, we can still chart and we can still capture the billing and everything like that in our EHR as normal.
So as a follow-up to that, Emily, I see that Dr. Boucher is actually in his office. Do the physicians need to actually be in their office, or can they be doing this from home?
No, we have no restrictions on the location of the distant site practitioner. Even prior to the COVID-19 public health emergency and all of the associated changes, we actually have never specified where the distant site practitioner needs to be located. So they definitely can furnish services from their home.
Okay, great.
That's a great point too for, if a physician were to get quarantined, they still got to keep the lights on. They might not be sick. They don't want to go play golf every day. They want to get something done where they're bringing in revenue and providing patient care, so they could do telemedicine visits from home, or practices where they're trying to stagger their providers either because they're not busy or they're trying to have a pool that's being exposed and a pool that's staying safe and not being exposed, is to have some working remotely doing telemedicine visits from home, and then another pool that's in the office seeing patients face to face. So there's that, certainly that ability really makes it easier to implement for practices and to be more flexible to meet patients' needs and physicians' needs.
we've been getting a lot of questions about consent, some about HIPAA consent or consent for care. Is that something that is done through the telemedicine app or that's done beforehand? How are you handling that, Dr. Boucher? CMS, are there any specific restrictions on that?
We're just doing it over text. So they basically get a text in advance that they click through and hit a couple buttons on their phone to sign the consent form, which is just kind of a very standard telemedicine consent form. And I believe, and I'll probably just plug my ears while Emily gives the correct response, but a lot of the requirements for consent have been relaxed in this telemedicine age to allow for visits to be carried out without, being able to sign a form being what stops you from getting the patient care that you need.
That's exactly right. So in instances where we have made specific requirements around consent, we've moved to relax a number of those. We really don't want sort of Medicare payment policy and our payment policies around beneficiary consent to interfere with the provision of care. In terms of HIPAA, I can't really speak to HIPAA. That's not quite my area, but the agency overall has moved to relax as much as we can.
In terms of the telehealth billing, so do you bill another telehealth visit during the follow-up of the initial visit? Is that a separate bill or a separate payment?
So in instances for certain of the communication technology-based services or virtual services, there's language in their code descriptors that specifies that if a visit occurs within a certain time, like an in-person, in this case, telehealth standing in for in-person, visit occurs within a certain time frame. I believe it's 7 days prior, 14 days prior and 7 days post or something like that. Then it would then be actually considered bundled into whatever the in-person visit that resulted from that kind of short, like virtual check-in or whatever. For regular telehealth, there's no sort of restrictions. Provided that you're meeting the required elements of the service, you can bill for the service, regardless of sort of when it happens in proximity to another telehealth service.
Okay. And then another one we've gotten a lot of questions about is PT, OT, and speech language pathology services. Are any of these covered now?
So right now, we added a number of the PT, OT, and SLP evaluation services to the telehealth list so that they could be furnished by, in the case where there is a physician or a practitioner who is otherwise able to bill for Medicare telehealth, that they could bill for those services. Right now, in the statute, there's a list of practitioners who are eligible to furnish Medicare telehealth services, and unfortunately, PT, OTs, and SLPs are not on that list. But we've definitely heard about sort of the need and the utility of furnishing certain of those therapy services via telehealth, and so that's something else we're considering with our CARES Act waiver authority, is sort of whether we would make some adjustments to the eligible practitioners who couldn't furnish Medicare telehealth.
Okay, we are getting a number of questions about the HIPAA regulations as it regards to telemedicine. So HIPAA does have a exception for public health emergencies, and a lot of the HIPAA regulations have been eased for this. So I think people don't need to
yeah, that shouldn't be a hurdle at this point, because you can use FaceTime, you can use Skype, you can use, you could probably use basically anything that you can to connect to people at this moment, and then while you're getting all the stuff figured out to use a HIPAA compliant platform, at least be connecting with your patients over Skype, Zoom, FaceTime, something like that, while you're working on getting an actual HIPAA compliant measure up and running, so that when PHE ends, then you have a HIPAA compliant platform going forward.
Emily, a lot of big push here for PT and speech language. Just going to tell you that right now. Dr. Boucher, yeah. You're working
I was just going to say that's very consistent with what we've been hearing, and we're very much working on it.
Okay. Dr. Boucher, have you had any kind of issue with timing and inefficiency with people not being able to log on? I think there's a lot of concern with some clinicians that this is really going to be hard to do and it's going to take a while. So, Dr. Boucher, what are you finding?
Yeah, I actually talked about this on my podcast last week. I have a person that I talked with about the inefficiencies of telemedicine visits. And really, I think that for one, most people aren't as busy. So you got more time and buffer, and it's getting a patient and the E&M code and everything like that, you're going to have to relax your expectations a little bit to realize that, okay, we're not having as many patients. We're going to serve the patients that we can, and it might not be as convenient, but it will still get the job done. I think a lot of those things can be helped along if you have your staff prep the patient, meaning they text them in advance or connect with them so that they know that their visit is at this time. They're told, have a room where there's adequate lighting, you've got good Wi-Fi, all of those things in place. If you can give them the patients a little heads up, then they're much more eager and able to get things right. And then realizing too that patients are all sitting at home, not doing anything for the most part right now. And so if the visit was supposed to be at 2 and there's a tech issue and you need to circle back at 2:30, they're probably still at home doing nothing. And so they'll be happy to talk with you half an hour later if it means that you're able to continue seeing patients in the office and then circle back to them. I had to do that yesterday because the mom had given us the wrong phone number. And so I called her phone, we spent all this time, and then we just circled back a couple hours later and they were still at home. They had done nap time and snacks and everything like that. And then we connected. So I think patients' expectations are relaxed, and our expectations of how smooth a visit go will just have to relax a little bit as we're figuring all this out. But it can still be quite efficient. And the last thing I'll say, my partners and I, and talking with a lot of others, these visits are much shorter. One, because there's not as much chit chat when you're online as in face-to-face, and it's more, what's the problem? Ask the questions. Right. Get the clarification. Okay, here's the solution. Go forth. And, so the visits are actually a lot shorter, which my colleagues have all, even the ones that kind of are long-winded, have found that their visit times for even complex behavioral things are much shorter because everyone's just kind of to the point and then move on.
Yeah, we've heard the same thing from a number of other clinicians over the last couple weeks. Emily, a lot of pushback here about these audio-only codes, that the payment's very low and it's not very useful. Are you looking at that at all in terms of increasing reimbursement for those audio-only codes?
Yes, that's definitely something we're considering.
Okay, great. Let's see. Oh, we are actually at the top of the hour. There are so many questions here, but I did want to mention that Emily had told us earlier that they are doing these office hours twice a week at CMS where you can call in and get your question answered. Emily, you want to tell folks about that?
Yeah, so and I will try to find a link to send out after this webinar, but every Tuesday and Thursday from 5 to 6 p.m. Eastern time, CMS staff is hosting, we're calling them office hours, and what those are opportunities for people to call in and ask questions about sort of the agency's, not just telehealth, but the agency-wide sort of COVID-19 policies. So I'm sure that there's information on the CMS website on that, and I'll try to find a link to send out as well.
Yeah, we'll send it out to everybody later today, and when we also send out a link to the recording for this session today, so you guys can, I know we went through a lot of information really quickly today, so we will be sending that out to everybody. One more question, Emily, for you on reimbursement. Are the payments that they're being reimbursed through telehealth the same reimbursement amounts as they would be if they were in person?
Yes, that is correct. And that's one of the reasons why we decided to, rather than using place of service 2, to allow practitioners to use whatever place of service they would have used had the service occurred in person, because in certain instances, there's actually a site of service differential between the facility and the non-facility payment rate. And we wanted to really, and the place of service 2 reimburses at the facility rate across the board. And we really wanted to preserve the sort of revenue streams for practitioners as they sort of move more of their practices into the virtual space.
Thank you.
That is great to hear. That is great. I'm sure Dr. Boucher is happy to hear that.
Oh, yes, for sure. Although my back is getting so sore from sitting so long, I actually had to steal a standing desk from our billers who are working from home now because I just can't sit like this for so long.
Welcome to the rest of us in office jobs.
I know.
Okay, well, I do want to thank all of our panelists today, Emily, Dr. Boucher, Andy Gila. I want to thank UpDocs again for their generosity supporting the program today. We are sending out to everybody a number of things. We'll send them out. The recording, the video, the slides of this will be up by tomorrow. We will send you a link to the information Emily just cited about the Tuesday, Thursday night office hours where you can go in person and ask you questions. We got a lot of very specific questions about codes and things, which we didn't want to go in today, but I know that those will be answered if you reach out to CMS. So go ahead and do that. And thank you so much, everybody, for joining us today. Thank you again to our panelists. Have a wonderful day. Stay safe and separate.
Bye, guys. Take care and separate.
Bye.
Take care, everyone.